This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation. Today's case is...
I keep on falling.
The patient is a 60-year-old male with no past medical history and also no previous doctor visits.
He presents with 1 week of worsening headaches, visual field changes, and blurred vision.
He has episodic blurry vision lasting 15 to 20 seconds with visual field cuts and periods in which he felt he was falling or leaning to the left when he walked.
The episodes had initially started 3 years ago, but they were very infrequent, occurring once every several months, and in between episodes, he did not have any problems.
He is only now presenting to the ED because for the last week, the episodes are daily.
Randomly, his friend in the room also reports that he feels the patient looks very red.
Vitals were unremarkable, though exam is notable for generalized plethora or flushing of the skin, more marked on his face and neck.
He also seems to have some clubbing to his fingers and mild bilateral pitting pedal edema.
Neuroexam was notable for truncal ataxia, and the patient seems to lean to the left while seated and also when walking.
He also interestingly had homonymous hemianopsia, though visual acuity was preserved.
This constellation of symptoms were concerning, and a stroke workup was initiated.
Workup including chest x-ray, EKG, point-of-care glucose, BMP, and coags were all unremarkable.
But wait, where is the CBC?
His CBC results were delayed, which is never a good sign. When it finally returned, his hemoglobin was 20.5.
Wowzers! Our patient by definition has erythrocytosis, which is defined as a hemoglobin above the normal range. 17.5 grams per deciliter in men and 16 in women, or a hematocrit above 52% in men and 48 in women.
In the meantime, his CT returned showing hypodense lesions within the anterior limb of the right internal capsule.
He was evaluated by neurology and underwent MRI showing multiple acute to subacute infarcts within the bilateral cerebellar hemispheres and the left occipital temporal lobe. He also had chronic lacunar infarcts and evidence of chronic microvascular ischemic changes as well.
The differential for erythrocytosis is broad and includes both primary and secondary causes.
The most common primary cause is polycythemia vera, with other congenital causes being exceedingly rare.
Secondary causes can be physiologically appropriate or inappropriate.
Physiologically appropriate erythrocytosis is a chronic response to hypoxia. This includes high altitude, hypoventilation syndromes, congenital cardiac disease, chronic carbon monoxide poisoning, congenital methemoglobinemia, and other causes.
Physiologically inappropriate erythrocytosis can be due to androgen or erythropoietin abuse seen in post-renal transplant patients and in malignancies that excrete ectopic erythropoietin, including renal cell carcinoma, hepatocellular carcinoma, hemangioblastoma, pheochromocytoma, and uterine leiomyomata.
For our purposes, we will focus on polycythemia vera, though it is important to keep in mind and rule out secondary causes of erythrocytosis.
Polycythemia vera is an increase in overall red cell mass, which can result in a number of complications due to the increased viscosity of the blood.
It is due to a genetic mutation and is not an inherited condition.
Patients with polycythemia vera can complain of a constellation of symptoms related to impaired oxygen delivery, high cellular turnover, and both bleeding and thrombotic complications.
Patients can complain of headaches, dizziness, weakness, chest pain, claudication, and shortness of breath due to decreased oxygen delivery.
The high cellular turnover can result in increases in uric acid and symptoms of gout in addition to hepatosplenomegaly.
Bleeding complications are seen in approximately 1% of patients with polycythemia vera, including epistaxis, gum bleeding, ecchymosis, and GI bleed.
Equally common are thrombotic complications including venous thrombosis or thromboembolism and an increased prevalence of stroke and other arterial thromboses, as was the case with our patient.
Particularly interesting are the odd symptoms, such as aquagenic pruritus or severe itching after exposure to hot water.
And erythromelalgia, or periodic attacks of redness, swelling, and pain in the hands and or feet.
Back to our patient, he was admitted to neurology and had a relatively uncomplicated hospital course. During his admission, he was seen by hematology and transfusion medicine.
Due to his acute stroke, he underwent urgent therapeutic phlebotomy with a goal hematocrit less than 45%.
He was initiated on aspirin 325 milligrams daily and hydroxyurea 1 gram twice a day, while workup was performed to rule out secondary causes of erythrocytosis.
His JAK2 was positive, confirming a diagnosis of polycythemia vera.
To summarize, consider polycythemia vera as an unusual cause for acute stroke.
The differential for erythrocytosis includes chronic hypoxia, erythropoietin or androgen abuse, and malignancies.
Consider thrombotic events and also clinically significant bleeds in the patient with polycythemia vera.
In patients with acute symptoms secondary to erythrocytosis, mainstay of therapy includes therapeutic phlebotomy, hydroxyurea, and aspirin.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLLou.
Thanks for listening.